Luigi? We're live, guys. Do you hear me? Does anybody hear me? Hello?
I can hear you.
So go live. We ready?
Oh, okay. I thought Luigi was going to say something. I'm happy to go live.
I'm waiting for him. Luigi. Is he not? Dr. DiBiase? I don't know if he can hear us.
I'm not sure he can hear. So he's saying something.
Luigi? We can't hear you. We can't hear you.
Can you hear me, Luigi? I don't know. Maybe we should just proceed.
Let's just proceed. Dr. Fisher, just go ahead. I'm sorry for the inconvenience.
Okay. Well, everybody, I would like to welcome you to today's session. It's called anti-tachycardia pacing, not to be confused with adenosine triphosphate, the other ATP. Now that this is a cardiology meeting, it's anti-tachycardia pacing. And of course, my screen is frozen. We'll go back to Dr. Seymour Furman, who is a giant in the field, was working here at Montefiore, and did the first transvenous pacemaker for bradycardia pacing. And this is, in fact, the first patient in 1958 who ever received a transvenous pacemaker. And that's Dr. Furman in his younger days. A little bit of background. It's hard to talk about anti-tachycardia pacing without providing some background in electrophysiology and pathophysiology, so we'll do that. But I want to underscore too that pacing can be used for prevention of tachycardias and also for support, hemodynamic support during a tachycardia that you just can't stop. Obviously, that's a temporary situation, both prevention, which can be long-term, and support during ongoing tachycardia. It's what you do to bail the patient out until you can come up with something definitive. Termination of an event is important. And then after you terminate it, of course, you go on and do something more definitive like ablation or medications or whatever. All the while, you want to be avoiding the so-called 800-pound gorillas. You don't want to accelerate the tachycardia and create a more rapid tachycardia than the patient originally had. You don't want to subject the patient to shocks, either external shocks or from an ICD. And you certainly don't want to end up with a full cardiac arrest. So although many of us are most familiar with anti-tachycardia pacing as burst pacing for termination, any of these methods can, in some cases, result in a adverse outcome. We should look back at some of the pathophysiology and think, what are some of the main tachycardia mechanisms? You can think about automaticity, which you might want to think of as like the sinus node, but just simply too fast. A reentrant mechanism in which the rhythm goes around in a circle of some sort is the most common and is the one where most of the ATP variations are used. There are also triggered arrhythmias, which is sort of a cross, if you like, between automaticity and reentry, with some of its own bells and whistles that we'll be talking about. And some long QT, Brugada, Torsade are examples of triggered rhythms. With automaticity, remember the action potential has a depolarization. It repolarizes, comes down to a totally repolarized state. And if it's a pacemaker type cell or an irritated working myocardium cell, it will begin to depolarize again. So you'll have an upslanting portion. And the steepness of the upslant, which is called phase 4, the wideness of the QRS, all have an effect on how rapid this tachycardia is. There's also something called the threshold potential, which is shown at this sort of knuckle here. And when the depolarization reaches that level, it's then an all or none situation that is launched and the cell depolarizes. Unfortunately, we have to talk a little bit about refractory periods. Refractory periods are zones in which a stimulus cannot capture the heart, or where capture results in altered depolarization and conduction. And refractory periods exist for individual cells. They may exist within a cell, and I'll show you some examples of that. And it may also appear in strings of cells or circuits. Because as you move, for example, in a circuit like WPW, which goes from the atrium to the AV node, to the bundle branches, to the working myocardium, to the Kent bundle, back up to the atrium, those cells all have somewhat different refractory periods, and that has fundamental importance in the initiation and termination of reentry tachycardias. You need to know that in terms of important refractory periods, you have the effective refractory period, which is very similar to something called the absolute refractory period. And even a very high-powered or high-amplitude stimulus given during the effective refractory period will fail to depolarize the cell and, in fact, may destroy the cell. Once you get beyond the ERP, other things happen, which we'll see now. Here's a cell just beyond the ERP, which is receiving a stimulus during its so-called phase 3. And the action potential that is generated looks different. It's slantier, and it turns out that slanty action potentials conduct more poorly to the next cell in line and also conduct more slowly. So you can get a potential, but it's not a very good one if you put a stimulus at that point, and that will have an effect on some of our ATP discussion. Here's again a cartoon of a cell with an effective refractory period followed by a stippled zone, which is the relative refractory period. And then once you get beyond that, the cell is fully repolarized until it reaches the threshold potential and fires off again. Again, if you have a stimulus during that relative refractory period, as shown down here in the stippled area, it will depolarize but move cardium. And in some of these diagrams, you'll have a period or a spot where the circuit is and the place where you or somebody may be stimulating, because that can be important. Now, this is not a new idea. Mines thought of this more than 100 years ago, and he did it on jellyfish mantles. Was by slicing them, he found that he could show electrical currents going around the edge of these mantles, and you'll notice the same kind of convention, which is a completely dark area represents the refractory period of this tissue, and the stippled area represents the relative refractory period of that. And he was able to reproduce reentrant electrical activity in the mantles of jellyfish. And we've remembered it ever since, no doubt, since maybe he gobbled some down as a sign of early Prevagen, which, as you know, is allegedly made out of jellyfish. Now, if you have a circle or a reentrant circuit, usually you think of something that is an anatomical obstacle, like here is a set of Purkinje fibers going into the muscle, and there is a triangular sort of affair here. Other times it's maybe circular, or in any event is bound on each side by the limits of the tissue that it's going through. The bundle branch has a sheath around it that kind of keeps it in inside certain limits. Alessi and Yancey also described something called a functional reentry, or what they call the leading circle hypothesis, in which there is a wavefront that travels around a central zone, which is always refractory because it's being fired on, shall we say, by this circular continuous wavefront. And just another example from, in this case, Stan Natel, who is a basic scientist who has this picture of that. And I would think of that as something like a hurricane, which is able to move around on the ocean surface with no particular bounds. It doesn't follow a track. It goes where the pressure takes it. And you can have several hurricanes going at once. And this is a little bit like some of the areas in the atrium that may be responsible for atrial fibrillation. Some people are extremely interested in those and claim to have found specific rotors, although it is hard to find in the atrium because even if they exist, they move around, and they move around very quickly. So that remains an open question, but conceptually, you can have this reentrant circuit that is not bound by specific limits, but is able to skitter around the surface of the heart. Now, I mentioned that there could be reentry within a cell, and that's because the cell wall itself has, of course, an endocardium, a thick muscular zone, and an epicardium. And they do not repolarize necessarily at the same time. And if there is a great dispersion of refractoriness between cells that are still depolarized and maybe a different layer which has begun to repolarize, then there can be current flowing from the still depolarized part to the repolarized part, and the cell itself can be its own reentrant circuit, and that's called phase 2 reentry because it happens during this dome part of the cell action potential, which is known as phase 2. And you can have a number of other abnormalities. Here's enhanced automaticity, as again we talked about, dependent on the upslope, the QRS or action potential duration. You can have early after depolarizations, which are known as EADS, and they occur during phase 3 and what might have been phase 4, but these are again cells which have repolarized parts that depolarize another part of the very same cell, and this can become an ongoing matter, and in fact it can become what looks like a polymorphic ventricular tachycardia. Also, there are some cells where a stimulus or an event that occurs after the cell has repolarized can make a little bump, which is called an delayed after depolarization. And if that little bump reaches the threshold potential, then it too can start off a rhythm which is confined to possibly a cell or a small area of cells. So let's get on now to ATP. And again, remember that we're going to be looking at prevention, support hemodynamically during an ongoing tachycardia, and termination, and avoiding those gorillas in the room. Let's talk first about prevention of tachycardia. You can pace the atrium or ventricle at rates slightly faster than sinus rhythm. That seems to work a little better for the ventricle than for the atrium, and it's been shown with serial Holter monitors at different rates. And for many years, when we really didn't have any treatment for conditions like long QT or Brugada, it was found that giving people pacing at rates slightly higher than the usual sinus rhythm, let's say 100 beats per minute, would tend to prevent recurrences. You can also prevent dispersion between different parts of the heart by dual site pacing. I mentioned atrial pacing there, but it can also be ventricular pacing, as we might get with a CRT device or a bibeam. And pacing at areas which cause the right and left atrium or the right and left ventricle or parts of them to depolarize more nearly simultaneously can have favorable hemodynamic effects by narrowing the complex, but also can be anti-tachycardia. Burst pacing is one of those terms that has several meanings. It can mean overdrive pacing, which itself has two meanings. It can mean pacing at rates just above the sinus rhythm, like we just saw, to prevent tachycardias, or rapid pacing at a moderately faster rate to initially kind of gain control of the tachycardia and then to stop it that way. Burst pacing usually implies brief pacing, I'll say considerably faster than the tachycardia. And that was used anecdotally and in rare cases, mostly on a temporary basis, starting in the 1960s, but was refined in the 1970s in ICUs and CCUs, where there were a lot of patients having VTAC for reasons we'll mention in a while. And it is the dominant mode of anti-tachy pacing that we see now in ICDs. Other techniques, which we'll go over briefly, have been tried in ICDs, but plain old vanilla burst pacing seems to be the most effective. This is a slide that actually illustrates many, many things. Here we're pacing VVI at 80, that's ventricular pacing at 80. If we lower the rate to 70, then after just a few seconds, the patient develops VTAC. And we do run into these patients. So in this case, on the bottom panel, the patient is bursted out of it with a burst of anti-tachycardia pacing. And then the pacemaker is reset again to 80, and that will then go on and on with no more ventricular tachycardia, just pacing that 10 beats per minute or so above the patient's spontaneous rate. How about, and that's something that can be used on the wards right now. So that's, we don't often use it, but it is available to anybody with a temporary or permanent pacemaker, and probably it should be used a little more often. How about support during an ongoing tachycardia? We may find situations in catecholamine states, drugs such as flecainide after open heart surgery, where the patient gets into tachycardias that are incessantly recurrent, or in fact that you just can't get rid of. You may be able to slow them down, but you just can't get rid of them. So sometimes also, just this is an example of how a wide QRS in a patient with SVT can cause hypotension. We have an SVT in this patient, which has been hard to stop, and the patient on the left has a narrow QRS, as you see at the bottom, and a blood pressure of around 100. When the patient develops a spontaneous bundle branch block, the blood pressure plummets and stays down there until we intervene. And there are several ways to intervene. This is something also which is eminently usable nowadays, and the fellows should certainly know about it. This is a slide that could have been done in the cardiac ICU or the coronary cardiac surgery ICU. And this is a technique described way back again in the early 70s. If you have a patient with a rapid SVT, this is a wide QRS, but it's SVT. You can see the atrial beats down at the bottom. And you pace the atrium even faster. Only 1 out of 2 of those beats gets down to the ventricle. So notice that on the right side of the slide, the ventricular rate is slowed down, and the blood pressure, in fact, jumped up to about 100. This is another example, the same thing. On the top, you see flutter with sort of 2 to 1. You see the flutter waves down below. But if you pace, shown by S, at a very rapid rate, you're able to capture the atrium, but look at the ventricular rate compared to the top panel. The ventricular rate is slowed down, and the patient is going to possibly weather that storm, or at least there's going to be having a better blood pressure and better hemodynamics. And of course, why should it be simple? In some patients, more than one mechanism can be at play. AFib, for example, starts as a super fast automatic rhythm in the pulmonary veins in many cases, particularly the paroxysmal atrial fibrillation. And when the wave reaches the atrium, where the refractory period is longer, only some beats conduct into the atrium because they hit the refractory period. That makes for a rapid, irregular depolarization of the atrial fibrillation. And again, we have the issue of maybe rotors that skim over the surface of the atrium. Here, you see some surface leads at a fast paper speed, but I think you can recognize AFib by the quivering kind of baseline. Here's the right atrium showing fractionated, beat up kind of waves. But the left superior pulmonary vein shows a very regular and very fast rhythm, 150 milliseconds, which is 600 beats per minute. But it's not fib, it's a perfectly regular organized rhythm, but the atrium simply can't go that fast, and therefore it begins to have this atrial fibrillation. Hurricanes again. And one thing we can't talk about for ATP is terminating atrial fibrillation or ventricular fibrillation. Once established, any kind of fibrillation cannot be terminated by pacing. Attempts were made a number of years ago to try to recognize some of these early beats coming out of the pulmonary veins and to do rapid pacing immediately and see if they could prevent the establishment of AFib. Didn't work very well. So going on for support, this is something that is useful only if you have a fancy machine, but we always talk about the atrial kick, where you get a little bit of an extra atrial boost. You can actually, during ventricular tachycardia that is incessant, you can use a pacemaker to put an extra stimulus right in between the successive ventricular stimuli and raise the blood pressure somewhat. And that's called AVT pacing. And on the left-hand side of the screen, you'll see this is a sort of a cartoon, low blood pressure. When a P wave arrives at just the right time, the next beat will have a better output. And so you can put these things in more frequently and get a better output. So you're doing atrial pacing during VTAC, and you can get some help. Needless to say, you can't do that with an ordinary pacemaker. You need a EP lab type stimulator in most cases. You can do dual site pacing. We talked about that briefly with CRT or BIV devices. May narrow the QRS and improve the blood pressure. And if a patient has VTAC that just won't go away, and this is a temporary or temporizing measure, you can go in and program the rate up to a higher rate and get a little bit of improvement. And this just shows, again, in this cartoon, pacing VT and then pacing one site and then pacing simultaneously. You get a narrower QRS and better blood pressure. Coupled pacing is also something which actually made it was first tried in the 1960s. And the idea there was to place a stimulus right after the refractory period in people with VTAC. At that point, the heart has not yet filled with blood, so you get very little output. And therefore, when the next beat comes along, there'll be extra filling of the heart using the Starling effect. and you'll get a better outcome. Unfortunately, it is very energy demanding because you're making a VTach rhythm beat even more, and you're not letting the heart have any output during that first beat. And therefore, there's the risk of getting VFib. And here's an example. Again, this particular one is actually the patient who had SVT, but with low blood pressure. And we put in an extra beat, and look at the blood pressure immediately gets better. But unfortunately, even though this was atrial pacing, the patient ended up with ventricular tachycardia. That was a pretty short episode of improvement. The technique is not used very much. One of the companies tried to modify an ICD only about 3 or 4 years ago to be able to do this, and the results were similar. The high number of people got VTach or VFib. So just in review here, for hemodynamic support, we can pace the atrium faster than the original atrial tachycardia, so that only half the beats get through to the ventricle. That is a viable technique that should be used. And number B, we have multi-site pacing, also doable with a 5V device and should be done probably more. AVT, giving the atrial kick, it's pretty safe, but it requires fancy equipment that make it not so much used. And coupled pacing, which is quite effective, but has a high risk of causing acceleration, VFib, or whatever. How about pacing to terminate the VT? So we have a VT going along, and we have the famous circles we're talking about, mines with a tail of refractoriness just shown in black, and an arrowhead showing the leading edge of the wavefront going around in this circuit. And there is a period during which a stimulus put into the heart will be unable to go anterogradely in the circuit because it's refractory, but can go retrogradely. It'll collide with the oncoming wavefront and extinguish itself, and that will stop the tachycardia. So you have to have a termination zone that you can access with your extra stimulus, and that's not always easy to do. You can do a kind of underdrive pacing where you just pace at a slower rate than the VT, go out for a cup of coffee, and hope that after a while a beat has landed in this termination zone and terminated the arrhythmia. It is generally pretty safe. It turns out that R-on-T phenomenon causing VFib are very rare. Trans-telephone monitoring of thousands upon thousands of patients over the years have shown only a handful of accelerations or precipitations of VTach with competitive pacing. You can get to the termination zone with carefully timed extra stimuli. If a stimulus late out here doesn't work, you move it in a little earlier and a little earlier and a little earlier and a little earlier, and you finally hit the termination zone. Pretty inefficient. There's ultra rapid trains where you give a stimulation right in the middle of the QRS. It doesn't capture because it's refractory. When it reaches the termination zone, it should terminate. And any other beats are going to be in the refractory period of the beat that's been generated by the train. That actually works pretty well, and my colleagues and I have studied that pretty carefully, and it's a viable method of termination for people whose tachycardias can be terminated by a single beat. Here's an example of its slow paper speed. The little notches are where single programmed extra stimuli are delivered progressively early till they finally hit the termination zone. And over here is a train which just works the first time. If there is a termination zone, the train will find it immediately. Now, why do we need bursts if this is all true? Well, here's our circle again, going around, It's emitting a wavefront into the myocardium, which then becomes refractory. And this second line with the dash marks on it is where we're stimulated, where the stimulator is. If we give one here right at the end of the refractory period, it's possible that it won't be able to get back to the circuit before the circuit has delivered another beat into the myocardium. So you will fail. You may be able to peel back the intervening refractory period by giving another closely coupled extra stimulus. And in fact, that worked here. It hits the antegrade refractory period, it goes retrograde in the circuit and extinguishes it. A burst is a simpler way to do the same thing. You start down here with the first beat of a burst that doesn't get back to the circuit. The next one does get back to the circuit. We finally get termination. Any other stimuli from the burst are gratuitous. They're not, they're more or less wasted, but they don't do any harm in general. So these techniques were actually incorporated into anti-tachy pacemakers that were automatic. This is one called the CyberTach. And during trans-telephone monitoring, the magnet, which we use to see how much battery is still left in the device, precipitated an SVT, it's sort of low amplitude complexes, was recognized by the CyberTach, which gave a burst and turned the patient back to sinus rhythm. We studied that in the CCU at Montefiore at some length and looked at more than 500 episodes of VT. This is a very early patient. We had a simple device. We had VT. We gave it a burst at 200, and this particular device had your options were 200, 400, 600, 800 beats per minute. So the next thing after 200, which didn't work, was 400, and amazingly it worked, and the patient didn't fibrillate. We rarely see this, that we have one-to-one capture at such huge rates and that it doesn't cause VFib. We later found that rates of around 240 would terminate the arrhythmia reliably. And because this lady had many episodes and was disabled, we gave her a implanted anti-tachy pacemaker. It did not have any defibrillator backup. So that was very scary. She actually survived that one and survived after a battery replacement, she survived another one and finally ended up getting a ICD when they became available. This is more or less the same thing. This is an Intertac, which is an automatic anti-tachycardia pacemaker implanted in the ventricle. Here you see a nice slow VT, a burst of rapid ventricular pacing, and restoration of sinus rhythm. It's very much like that woman I mentioned. So the burst pacing method is really pretty simple. Start pacing maybe 10 beats per minute above the tachycardia rate for maybe 10 captures. Then try a longer burst, say 15 captures, and then go up 25 beats per minute and see what happens then. Acceleration or fibrillation is likely if you get up to 250 or 300 beats in the ventricle. On the other hand, with atrial flutter of the typical type, you often have to get well above 300 beats per minute before you have termination. This is a very important concept and is the final concept you'll be happy to hear perhaps, really introduced by Al Waldo in the 1970s. He saw a whole bunch of patients who had atrial wires after open heart surgery and who developed atrial flutter. And so he studied the atrial flutter carefully and came up with the concept of entrainment, which we're now going to talk about briefly. He noticed in this, this is from a wire this is from Al Waldo, one of his papers, Notice that every stimulus here gives a somewhat negative potential on the left-hand side of the screen. If you paced slower than this, it would be a little different shape divot or negative complex. And finally, at some critical rate, the change of the atrial beat changes. Notice instead of being a sort of spike downwards for the atrial deflection, it's now a rounded upward spike. And at that point, if you turn off the pacemaker, the rhythm has been terminated. So in the CCU, you can go there and burst at 800 beats per minute and terminate the flutter, but you may get atrial fib, and then it's potluck whether that terminates or not. This way, you rarely get AFib, but you terminate the atrial flutter. So what Dr. Waldo thought, and this is really taken from his work, but it's converted into VTAC. Imagine that this box is a heart and with normal muscle, and the smaller box inside is a diseased area where conduction is slow. So during sinus rhythm, the beat comes in, it depolarizes the heart. I've drawn that as coming out as going in both directions, but it could be just one. In panel B, we have tachycardia, which has gone through the area of slow conduction and comes out and covers the whole heart with a stipple depolarization. And basically, because it's faster than sinus rhythm or whatever, it's taken over the heart, and the patient's now in VTAC. Well, if you pace at a certain slow rate, the pacing stimulus will create this white area, and it will take over a certain amount of the heart before the impulse comes out of the slow conducting diseased area and curls back on to the, or towards the part that's being paced. And if you go faster, you will depolarize more of the heart before the VTAC wave comes through. So there are actually two waves depolarizing the heart. There's your paced beat, and there is the actual tachycardia beat. And Waldo's concept then was that you are actually speeding up the tachycardia, because when all is said and done, your beat is going into the small area and it's coming out to the slow area and is making it go faster and faster. So finally, you get to a point in panel F at the bottom where it can't get into the slowly conducting area because of refractoriness, and the beats that are paced can't get back in because it's refractory as well, more or less like in panel A, and that's terminated the arrhythmia. Now, because you can actually see this change in the QRS complex or in the atrial complex if it's flutter, and that change stays the same at any given pacing rate. And as you go faster and faster, it slowly changes, but stays the same at a given pacing rate. Waldo called that overt entrainment because you can actually see it happen. We now talk a lot about concealed entrainment. And that happens when you pace within the area of slow conduction of disease. If you pace outside of it, up here where I'm circling, the impulse is going to go in all sorts of directions, and you'll get a certain complex shape. And if you pace here or here, you'll get a different shape, but it will be the same at any given pacing rate. Now, if you pace within the area of slow conduction, it will always come out of the area of slow and go around. Sorry, my pointer's not working. Go around in a circle and come back again. If you pace at number 2, it'll come back to the channel and go up and around again. It may take longer to get from stimulus to visible onset of the QRS, but you will see the same thing all the time. And because the shape of the QRS does not change as you speed up the rate, that is considered to be concealed entrainment. Now, we talk sometime about inappropriate bursts or treatment for tachycardias, but sometimes maybe that's debatable. For example, this is an ICD, and on a Holter, it was noted that the patient went into flutter fib kind of rhythm. The device detected it, gave a burst, which slowed it down for just a minute. You can see the flutter waves better, but sped right back up again. And so it tried faster anti-tachy pacing, again, without terminating the arrhythmia. So it gave a shock. Now, that restored sinus rhythm. It's listed as an inappropriate shock. Depending how sick the patient was with the rapidly conducted A flutter, maybe it isn't so inappropriate, but that's the terminology. So in conclusion, this is not really an ICD talk, but you should know that ICDs can deliver most of the ATP types that we discussed today. Some of those types were developed right here. They form the basis for a number of experiments, both in the dog lab, the human lab, with some volunteer house staff, and with lots of people. There have been a lot of improvements designed to alter diagnostics and minimize shocks as time's gone on, and the defibrillators are better now than they used to be. One of these changes, for example, is as follows. It's not obvious from this slide, but conventional means that as soon as the defibrillator detects a rapid rhythm above whatever it's programmed to detect, it will start charging up its batteries, and with a fairly minimal delay after that, we'll start treating. And a lot of people said, well, maybe a lot of those episodes would have terminated spontaneously. Why don't we let the VTach go for a longer time before we treat it? And sure enough, that was done. And the outcomes in terms of life and death and everything were about the same. And another alternative was to say, well, why don't we not treat unless the tachy is really fast? Because the really fast ones are actually more likely to terminate spontaneously than the slow ones. And that also turned out to be true. So you'll find some defibrillators now that seem to wait a month of Sundays before they deliver therapy. But before you are too concerned, check to make sure that that wasn't the intention. And of course, defibrillators can save lives in other ways too. This is a fairly famous picture of a defibrillator that stopped a bullet and saved the wearer. So in conclusion, there's a lot of different kinds of anti-tachy pacing. We've already had little panels for prevention and for hemodynamic support. This is underdrive here for terminating tachycardias. This is programmed extra stimuli and scanning techniques in which the extra stimuli are put in on a programmed and altering sequence. Train of rapid or ultra rapid stimulation, multiple programmed extra stimuli, bursts, which are usually defined as having stimuli that get faster and faster, but of each burst, the cycle length of the stimuli is about the same. You can put programmed extra stimuli at the end of a burst. You can have ramps, which go, in this case, going from fast to sort of slowing down. That's sometimes called a tune down, or the ramp can start slow and go faster. And you can have ramps that sort of go up, really grab the heart, and then tune it down. And all those things have been tried. And as I said, when all is said and done, the technique that's most often used is plain old vanilla burst pacing. So in conclusion, except for burst pacing of VT with ICDs, ATP variations are used much less in the modern era than they were, let's say, in the 80s and 90s. The reason for that is, in one part, because of ablation. We used to have patients come in with multiple admissions for the same arrhythmias. now we ablate them. Revascularization has made a huge difference in peri-infarction ventricular arrhythmias. We used to have multiple beds in the CCU at the same time, getting a series of drugs to try to squelch their VTAC following a myocardial infarction. That's much less common nowadays. ICDs are implanted after just a few days. We don't spend lots and lots of days testing out anti-tachycardia pacing modes or giving different medicines and so forth. And a combination of a kind of standard set of meds depending on patient condition together with ablation ICDs has made a big difference. However, less used also means less remembered, and a lot of physicians could do their patients good by being aware of the effectiveness of anti-tachycardia pacing in some clinical scenarios, temporary as well as permanent. Thank you.
Thank you very much, Dr. Fisher. I hope you can hear me now. Yes, so the technical problem was fixed. I was there before. So I'm Dr. DiBiase. I'm the section head of electrophysiology. Good afternoon, everybody. And I'm introducing Dr. Fisher at the end, but it has been a pleasure to listen to his lecture. Dr. Fisher is a professor emeritus and distinguished at the Albert Einstein College of Medicine, and he has made the history of electrophysiology and cardiology at this institution and in the world. He's a former president of the Heart Rhythm Society, one of the founders. And as you have seen and listened from his presentation, you know, he really went through the history. What we do today was not available many years ago. And he has the luxury of having seen things that, yes, we don't do anymore ATP now, but because somebody else has gone through the history and used that, and then the ablation came, and then things have changed over time. So Dr. Fisher supported the development of everything we do today in electrophysiology, and it has been a real pleasure to listen to this lecture. If there is any questions, please be able to do it. I will extend the question to Dr. Fisher. The question I have for him is, if you have to say one clinical scenario where you feel that currently we keep forgetting about ATP in the clinical practice, which is an example that you would mention to say?
I would mention the CSICU for termination of flutter. They're all set up. They all have a pacemaker. They have wires on the heart. We do have handheld rapid pacers. So all the fellows need to do is go up, switch out the pacemaker, and use it. Sometimes when it's not clear if the patient has AFib or silent atrium or whatever, in those patients, they should remember that they can hook up the wires to an EKG and just look at the intracardiac or the really epicardiac wires and see. Even in the past, we used some of those techniques, as I say, on a temporary basis. Some of them were not ever thought of for long term. And we use them for patients who got stuck in tachycardia for one reason or other. Could have been medicine, it could have been heart failure that was extremely bad, and maybe they had a sinus tachycardia that was really too fast. They always say that, you know, you can't shock somebody out of sinus rhythm, and sinus rhythm is usually a response to hemodynamic needs, but sometimes you can use it to slow those things down. And certainly you'll run into the occasional patient who will be a classic patient with recurrent VT episodes that instead of shocking them externally twice a day, it's much nicer to just pace them out. It became at one point very nonchalant. There was a nurse's note in the CCU in a patient who had a temporary pacemaker. I don't remember whether it was a temporary for heart block or for VTAC or whatever, but the patient had a temporary pacemaker. And the patient was having dinner, and the nurse's note said, patient having dinner, sitting in at the edge of the bed, went into VTAC. I paced him out of it, and he continued his meal. Just very routine. And we don't see that so much anymore. But you know, when we do see it, we should know that it's nicer than getting shocked.
Yeah. No, it's important what, you know, just as you mentioned in your final slide, you know, there are things that exist and that younger generation are unaware of because they are not routinely used, that are available at the bedside of the patient and can be very useful in situations where you have, you know, deterioration of the blood pressure or other things to, you know, at least temporarily solve the problem. Then still an ablation or any more invasive procedure and more advanced procedure can still be done, but the clinical, you know, resolution of the problem of the patient can be done with a simple anti-tachycardia pacing maneuver, which you very well presented. Are there any more questions?
John, I just wanted to say that sometimes a revision of history is extremely important. And I can't remember seeing a revision like the one you did today that it seems so well done, so relevant, and that makes so much sense. So I think we all learn a lot from this. And even though perhaps it's difficult to apply with the modern devices, the ATP today, you know, it's important to understand how it works. I just had one question out of curiosity. As you have the ability to change some of the programming in the permanent devices, particularly in the ICD devices, do you ever consider extending or shortening the period of ATP prior to shock, depending on the individual patient? Let's say LV function, tolerance of VT, presence of ischemia or no ischemia based on the history. Is it one parameter that you adjust? How safe is to extend ATP before shocking?
A very good question. The new default is to wait longer and let the patient have a faster rhythm. Now, how long are you waiting? The old ones were usually designed to give a shock within a couple of seconds after being charged. Nowadays, it tends to be in terms of beats rather than seconds. So you'd say, let's wait for 36 beats or 40 beats or something like that. Now, obviously, 40 beats at 140 beats per minute is a long time, and 40 beats at 300 beats per minute is a short time. So it's not likely that if they get a really fast rhythm, that they're going to suffer too much ischemia or whatever, because if it's really fast, it's not going to take too long to count up those 40 beats or 35 beats or whatever. So we're not talking about minutes and minutes of tachycardia. I should comment that all the devices, as a fail-safe, have a time, what they call a timeout, which means that If it's giving anti-tachycardia pacing for more than a certain amount of time and it's still detecting rapid rhythm, it'll deliver a shock and go into shock mode. So if you have a patient that you think is very delicate and can't tolerate VTAC, you can make the so-called timeout shorter, or you can say only give 3 pacing attempts before you shock. So you can program all around that issue that Dr. Garcia has raised.
And Dr. Garcia, to complete your question, all the current available device, we always program that with the strongest ATP possibility to avoid the shock, which is something that no patient would like to receive. And there were 2 trials performed, the pain-free 1, pain-free 2. All these trials try to, expand the programming of device to minimize at the max the possibility of the patient having the shock and terminating the VT as much as possible with this maneuver, which are integrated into all devices. The problem is they are not integrated in patient in CSICU or ICU, or where they don't have a device, they only have a temporary wire. And Dr. Fisher tried to say, when you have a wire, it's like you have a device. Before you even shock the patient, you should attempt other maneuver.
I will. There is a secret. We have hidden away in a closet several automatic anti-tachycardia devices, including an ICD with a special attachment in the header that allows it to attach to temporary pacemakers. So that should be known probably to the fellows. It's something you can program it. I think we use it once a year, and the main reason we only use it once a year is because we keep forgetting it. Irina knows where they are.
Okay, if Mario, any more questions?
I thought it was pretty clear so far. And I personally want to again recognize not only the depth and the importance of this presentation, but all the work that has been pioneered by John Fisher and his colleagues here at Montefiore that made possible that field to have developed in the way that has developed and be what it is today. That's an incredible accomplishment that he has done through his career.
So, Dr. Fisher, thank you very much for your brilliant lecture, your time and dedication, and I thank everybody connecting to this lecture today. Thank you.
Thanks to everybody for listening.